Welcome to the session on Black men overcoming prostate cancer disparities through screening, prevention, and genetics, sponsored by Facing Our Risk of Cancer Empowered. I'm Vabren Watts, a health science writer for Force. In my 15 years of science writing, I've never written about cancer until I joined the team of Force a little over a year ago. Through my coverage with the X-ray articles, I have learned a lot about multiple forms of cancer and their likelihood to be inherited. I was shocked actually by my risk for prostate cancer as a Black man, which is what led us to this session today. Did you know that we as Black men are 50% more likely to develop prostate cancer in our lifetime and twice as likely to die from the disease than our white counterparts? Given the higher risk of developing prostate cancer and dying from the disease, Black men are more likely to be saved by screening. Screening guidelines have been based on studies that include very few Black men, so they may underestimate screening benefits of this group. This also leads to the notion that despite the increased risk of developing prostate cancer and dying from it, Black men are underrepresented in clinical trials that test new therapies for prostate cancer, making up only 6.7% of patients. The biggest barrier seems to be the lack of awareness, both of the trials themselves and the possible benefits that they offer. Today, we are joined by two people, Dr. David L. Beckley, President Emeritus of Rusk College in Holly Springs, Mississippi, and a prostate cancer survivor, as well as Dr. Curtiland Deville, Medical Director at Johns Hopkins Proton Therapy Center, and Associate Professor of Radiation Oncology and Molecular Radiation Sciences. So we will lead this session pretty much just talking about the experience of prostate cancer with our survivor, as well as get some expert information from Dr. Deville, which we will call Kurt. So actually, I would like to start out with our survivor, which is, as I said, Dr. David Beckley, President Emeritus of Rusk College in Holly Springs, Mississippi. So David, so when were you diagnosed with prostate cancer?
Well, let me just kind of give it my prostate history, if you would. Let me start that way. During my tenure as president of Wilder College in Marshall, Texas, I ran into a couple of people who had prostate cancer. And talking with the local physician, he suggested that any Black male 40 and above should have an annual PSA. And since I was not 40 or above at that point, I kind of just followed the notion. But at 43, I insisted that my annual physical include a PSA. And initially, the PSA was, well, there was, the doctor can probably clear this up. There was two way of listing PSA rates, 0 point something, and then a whole number. And so as I started the prostate, I had the 0.01 and 2 and 3. And it was 42 when I started, and 56, my rate went to a whole number, which is that time 1, I think it was. And I was advised by my local practitioner, medical doctor, that if it go beyond 5, you need to do something about it. So as I walked through the process, and from 45 to 56, my number went to 3. And at that point, I decided that I need to look at some possibilities, because I was told to go to 5, then there's a possibility that the prostate could be penetrated with the problem and be attached somewhere else in the body. And he began to look at some type of a treatment. And we talked about 3 different treatments. We talked about what they used to call the radical surgery. Doctor, I hope if I misquote me, please correct me, what they call radical surgery. Then there was a nerve sparing surgery process, and then there was a seed process. And so I began to explore all of those different procedures. And my general practitioner, who moved to Mississippi from Florida, had prostate cancer 13 years before I got involved with trying to decide what to do. And he had the seeds implants, and the seeds implants had failed him, and he was trying to find a surgeon to take out his prostate. Had a hard time doing it. We finally found one enough to do that, and that's when we started exploring possibilities. And he told me I could watch it for a couple more years, or I could begin some type of treatment. I figured if I'm at 3, I don't want to take another chance, so I wanted to take it out. And then I began to look at the processes, the procedures. The 2 procedures that I nailed it down to was the radical surgery, which was told that could cause other problems in the body after the surgery was not done properly. And then there was a nerve sparing one that some fella in New York had created some years ago, had pretty well perfected. There was a person in Memphis who had been practicing that. So I went to see him. It's innocent enough, it was a fellow from South Africa who was practicing in Memphis. And so we agreed to do the surgery. And we did it. And so far, things are working out okay.
So you said, so I'm going to back up with a couple of things that you said. You said PSA test, and I want Kurt to chime in to tell us, for us who are watching, what is a PSA test?
Yeah, absolutely. And thanks again for the invitation. I'm really happy to be part of the panel and the discussion, and always excited to, not excited, but eager to speak on this topic and really reach, men who are particularly at risk in our communities for prostate cancer, because many don't know those statistics that you mentioned in the very beginning. And to Dr. Beckley, David, it's wonderful. I always encourage patients, when they're willing to tell their testimony, to sort of speak their story. I, as a physician, sometimes I can talk, for days on end regarding prostate cancer, but to hear it sometimes directly from the patient or the individual who has been through the process can be so much more powerful to the individual that's going through it as well. So I always appreciate and thank folks for sharing their testimony. But yeah, you went through a lot. So definitely some pieces we should break down there. The PSA test, kind of most importantly, step one, when we think about screening for prostate cancer, and screening, means taking someone who seems normal, healthy, but applying a test to see whether they actually have a disease or are risk for a disease. And in this case, we're talking about cancer, and prostate cancer specifically. And for prostate cancer, we're fortunate to have a blood test. There's a lot of controversy, and sometimes the PSA blood test gets a bad rap, but I always tell men, we are fortunate to have a simple blood test that can send us a signal, give us it's a marker, can send us a sign if there's a concern. And so PSA is prostate specific antigen. Basically, I tell patients it's a protein on a cell, on a prostate cell. So it basically is just something that we can use to estimate how much prostate tissue there is in the body. And so we start to get concerned if we see that number increasing over time and it's getting too high over a certain threshold. There's sort of this somewhat arbitrary line where we say, okay, we think there's enough risk that it's worth going in and now doing an invasive procedure, what we call a biopsy, to sample the prostate, to collect some cells to see if there's actually cancer within the gland. But because it is a marker and a little bit arbitrary, certainly there are men who have and the number we use, that cutoff is 4. You mentioned that number 5 is kind of the signal. So somewhere around that range, sort of 4 is this number that we've defined that there's enough risk to go in and do the biopsy. But certainly there are men who have PSAs that are lower in value and can have aggressive cancer within their prostate. And there are men that can have PSAs above a 4 that may have no cancer or just very unaggressive, or we say indolent prostate cancer. And so the PSA is, I would say, it's not the be all end all. It's just kind of a step one, and how we interpret and use it is what really matters. And more than just that sort of, I keep saying arbitrary because I try to drive that home, that point home to people. It's not that the PSA is wrong. It's just we have to use it in the right context. So 4 is somewhat arbitrary. We also want to look at other parameters like you went through. We want to look at the velocity and the doubling time. How quickly is that PSA increasing over time? If it's a very slow trend upward, then we won't get worried as we check it year to year. But if we start to see certain things like it increased in 2 points in a single year, so you checked it one year, it was 2, and then the next year went to 4, even 1, and it went to 3.5. Well, we're going to that's a big jump in 1 year, where we should be advising testing. And very often I hear men say, well, I was told it wasn't quite at a 4 or a 5 yet, but you could see in the trend that it was either increasing very quickly or it took a big jump in a year that should have sparked, more attention than it got.
So based on I think about Dave's experience, it seemed like he was pretty much on it at a young age about it. I will say I'm 41 and have not had a prostate. Get
it.
Yeah. Yeah. So I guess the first step is for someone, I would say like me, like what is the first step of like getting the prostate?
Exactly. Yeah. Let's even go a step backwards. So when do we begin screening or thinking about screening? And there's been a lot of controversy over time that, we don't necessarily have to rehash the details, but there's sort of a need to clarify because, much with many things in life, this sort of the data changes, you get, one recommendation is made and then it's changed back. And so the current guidelines recommend what we call a shared decision-making approach. So it's a conversation between the primary care doctor, a urologist with the patient around the risk and benefit of screening. Should we test for prostate cancer? Should we take that PSA test? And the time that when that occurs, the main number that's thrown out is usually at age 50. By age 50, you should consider screening. But if you're in a high risk group, you should do it much earlier. And so Black men, men of African descent, by definition, are in a high risk category, period, because of those numbers you talked about before. We have a higher rate incidence of getting prostate cancer, and then the death rate is much higher. Probably, as we can talk about, it has to do a lot with, access to care. Are we getting appropriate care? Are we getting timely care? Because when we do get appropriate, timely, and comparable care, we do just as well as our white counterparts. But nonetheless, so we have to start our screening sooner. And so that's at age 45 rather than age 50. But the other high risk categories are men that have had multiple, what we call, have a single first degree relative. So if it runs in your family, you have a family history. And by first degree relative, we mean specifically father, I say father, brother, or son. If one person has it, the other is much more likely to also get prostate cancer. So father, brother, son. And then if you have multiple first degree relatives, so multiple brothers or, that sort of thing, then it's actually even at age 40, you could begin screening. So a Black man with multiple family members at age 40. And many societies like the American Urologic Association will advocate for starting that early screening anyway. At age 40, you could establish a baseline PSA, and then you can follow it over time. If it's very low, they may not even need to check it every year. They might do every 2 years, for example, if it's below a 2. And so the urologists, and that's why we talk about that shared decision-making approach. They should be kind of counseling you, or the primary care doctor, walking through these options of the screening, assessing well your history and sort of knowing how early do we need to start on that screening pathway. And the other thing I'll add is very often, by the time I see men, they're diagnosed, we need to come up with a treatment plan, and I'll ask them, was the PSA being monitored? Were you being screened for prostate cancer? And they very often will say, well, I don't know, I thought I was. And so I say, if you thought you were, you weren't being appropriately screened. If you don't know the answer to that and can say definitively yes or no, then you weren't appropriately being screened, because you should be having a conversation, even if they're checking that PSA blood test and you see it kind of on the list of labs that are drawn. There really should be a conversation about assessing your family history for prostate cancer and other cancers, frankly, but prostate cancer, since we're talking about that today. And then, so knowing the family history, and then again, your genetic ancestry, being of African descent for Black men, we have a higher rate in this country. So it's really important that we should be having those conversations with our primary care doctors.
So I want to hit on.
I agree with that, what was said by the doctor. The thing is that we had an uncle who had prostate cancer, because he had his prostate, he was diagnosed after I had my surgery. And that's the only known case in the family that I'm aware of with it. But as I said, I was in Texas when I started talking with fellows about the prostate process. And I was all the information you just shared about it's heavy in the Black community, because Black males have certain priorities that we want to do and not want to go damage certain areas, as they call it. but and I tell the fellows, you got a choice. Either you monitor it, or you ignore it, or you become fertilizer for a tree. And that may sound cruel, but that's exactly what will happen. And we're losing too many Black men because they refuse to go and have the test. And then when they find the test, they try to delay the surgery part until it's too late.
And I think it's important to acknowledge that stigma, basically. There's sort of a stigma around, talking about the prostate. What is the prostate? What does the prostate do? Where it sits in our body, the function that it provides to men. And so, often people just don't want to talk about it at all, really. And very often I'll tell them, what you described, the minute they say they've been diagnosed with prostate cancer and they start to talk to other people, they realize how many other people they know actually had prostate cancer, went through these experiences and just had not shared that, even family, friends, the sort of broader network. And we know from the numbers that you quoted that is the case, but it's just not the conversations that are happening. So really important why we're having this conversation today.
The other thing about it, that once you open up your mind and share with other people, you'll be surprised to know what people in your community already had it. There's a fraternity of men out there, and they're
Mhm.
looking to talk to people about their experiences, make suggestions, recommendations. I get calls from all across my fraternity brothers. I understand you have prostate cancer. I've been tested. What do I need to do? Go get the test and monitor it. And they get above, like I said, get above a whole number of 3 to 4, you need to do something about it. And I did when I went in at the 3, they did do the biopsy and they found 2 spots. I said we need to get them out. And so let's decide which way to get them out. And that's what we did. And I've had that was been 21 years ago now. And I still, my numbers are still 0.1. The funny thing about when they changed the scale rating from the whole numbers to the 0 point something was 0.9. I said, what does that mean? He said, don't worry. So you're okay. You're okay. But it's been that way for the last 20 plus years now. But I get the test twice a year, one from VA and one from a medical doctor, and have them check on each other to make sure we're in the same range. That whatnot.
One of the things that I heard you say that we talked about, so I want to go back to, we were talking about family history of like prostate cancer or other cancers, because we do know that sometimes you may have prostate cancer may be linked to other hereditary cancers. And so David, did they ask you about your family history for cancer?
Yeah, my mother had breast cancer, and she died with breast cancer before I had my diagnosis of having the PSA situation. And I think that's the only one that I'm aware of with a cancer type death close to me, is my mother. Now we had a cousin, Eddie died with cancer also, but no, I don't think he had prostate cancer. I'm not aware of it anyway. Yeah.
Okay. And did you did they offer undergo any type of genetic testing just to see if it was hereditary?
No. I didn't say, and you need to just tell me if I have with my PSA scores in the danger zone, and then we go from that point. We didn't go to further. Yeah.
Okay. All right. So Kurt, I will ask, in some cases, that it is, a hereditary thing with prostate cancer. How important is genetic testing?
Yeah, and I think it's important to acknowledge our understanding of genetics, and prostate cancer specifically, has evolved, and particularly in the most recent years, even our understanding is increasing. I think it's the era that we're entering as we hear about sort of personalized medicine. It's really understanding the genes of the tumor, the genes of the patient, and what are they at risk for developing, and those can help to predict appropriate treatments, response to treatment. That's really the area we're entering, and really sort of maximizing our knowledge in that. So for currently, anytime if you're suspicious about, if you have a strong family history of multiple cancers, that should trigger, right away to consider some genetic testing. And it's particularly cancers at younger ages, especially in particular. So that's, not your case in particular, Dr. Beckley, but for other patients, if you do have multiple family members, it should spark the clinician, the physician, and usually at this point, it would be the oncologist, whoever sort of managing the cancer treatment, to think about that. And very often we'll refer to a medical geneticist specifically, who can run these tests. But in terms of prostate cancer guidelines, so anyone who is diagnosed with, let me just say one thing. So most commonly, most men who are diagnosed with prostate cancer, the most common scenario is that they say they didn't have any family history. It is the most common cancer in men. So at the end of the day, it's still the most common scenario that they say they don't know, they didn't have a family history, they don't know. But there are certain links to family history, and there are some certain inherited specific types of prostate cancer that can run in families. Certain genes, what we call cancer genes, can be linked to prostate cancer. And like for the breast cancer gene, for example, can manifest in men as prostate cancer. And so the national guidelines, if we look at, for example, the NCCN, the National Cancer Comprehensive Network, which I call sort of the national guidelines, and those are free and available to people online at nccn.org. They recently added genetic testing for any man who's diagnosed with aggressive prostate cancer that, at the time of the diagnosis has either spread beyond the prostate, so what we call metastatic prostate cancer, or if it's not spread, but they have aggressive features, such as a high Gleason score. So when we do the biopsy and we sample the prostate, it's assigned a score that we call the Gleason score.
Right.
And so anyone with a high risk score should also undergo genetic testing. And so that's assessing, and this is pretty easy and straightforward these days. There's a variety of commercially available kits that you just spit in a tube, or they do a swab and it gets sent off. And it's testing for specific cancer genes or mutations, abnormalities, and some of which, we know are cancer genes that we know, and they're associated with certain cancers. And sometimes there may be some abnormalities that are just noted. And sometimes I tell the patient, we just don't know what those mean yet. And over time, as our understanding improves, we may start to understand better, does that lead to other types of cancer or predict for response to other types of treatment? So that genetic testing should be done for all men with aggressive prostate cancer.
Go back to the Gleason score. My Gleason score was lower than 5. But I guess I grew up with the PSA score. That's what I looked at. How do you explain that? Mm-hmm. Is there an explanation?
No, absolutely. And so that's why, I sort of tell people they're kind of data points, right? And so we're bringing in all of the information. It's like the detective, right? He doesn't go by one piece of evidence. That you need all that evidence to pull together the story. And the story we're pulling together is, what is this patient in front of us? What is their prostate cancer telling us? How aggressive is it? Where is it located? What do we need to do to treat it? And so nationally, what we do, and this is described in the NCCN in the guidelines, actually nationally, now internationally, what's developed for prostate cancer is called the risk group stratification. And that incorporates the PSA, the marker in the blood, the Gleason score, which is the marker from the tissue, and then what we call the tumor stage. And that is, where do we see signs of cancer if we do imaging like an MRI or a CAT scan or a bone scan, or did we feel anything, which we haven't talked about, but that digital rectal exam, the sort of finger test where you're have a physical exam, the physician, palpates the prostate, and if they feel a nodule or an abnormality. So we what we call stage the prostate cancer based on those findings, the digital or imaging. And then we take those variables, the PSA, the blood test, and the tumor stage, and we assign a risk group. And that risk group, really the definition is, what is the risk of that cancer recurring or coming back after the initial treatment? Is it a high risk? Is it an intermediate risk? Or is it a low risk? But in some ways, it's kind of, I tell patients, the aggressiveness of the cancer. Is it, high, medium, sort of low? And then that helps us define appropriate treatments. So in your case, it sounds like the cancer was picked up early, which is what we want. It's a good thing. And so it was probably classified in that low risk box, in that early, or what we would just call an early stage prostate cancer. And so then the treatment options at that point are either to do observation, which we used to call watchful waiting, but we know that's not a good term anymore. It's called surveillance or active surveillance, meaning we're going to closely keep an eye on that cancer with PSA blood tests and an occasional MRI or biopsy, so that when we see it becoming more aggressive, then we're going to jump in with treatment. But that helps us avoid over-treatment, right, of unnecessary cancer that is unaggressive, and sometimes we can defer or delay treatment for patients. But the alternative is, if we don't do that surveillance and we do treatment, that's where we're deciding between the surgery and the radiation, as you were talking through before, and navigating through those options.
Go back to let me ask you a question about chemo. One of the reasons why I decided to do the what they call nerve sparing surgery is that I was told that once they perform the surgery, they could do all the testing to determine whether there's a need for any chemo before they completed the process. I guess close your body, whatever you call it that way. And there was no need for chemo in my case, or any other type of treatment for the cancer, because it's confined to the prostate gland, I was told, and the nerve endings did not test anything positive at that point. Could you elaborate a little bit on that? Because fellow may hear that also, may have a different idea about the surgery, whatnot. Yeah,
just to walk through that briefly. I'll try not to take it too long. I mean, because this is when we have the consultation with the patient, we're sort of walking through, and it's usually a 60 to 90 minute conversation, because there's a lot of things we got to go through. But so I tell people you can take the surgery road or you can take the radiation road, and that the best available evidence tells us that those treatments are equally effective to eliminate the cancer, and that's why they're presented to you both upfront as comparable options. But they're obviously very different in terms of the logistics, the nuances, some of those details that you're talking about. Chemotherapy for prostate, like chemotherapy very often refers to a very specific like chemical therapy. If we think about the category of like systemic treatments or treatments that go into the whole body, what you're likely talking about is what is often called hormonal therapy. And prostate cancer responds to hormone manipulation. And essentially, we're not giving hormones, we're taking away the body's ability to make testosterone when we give hormones. So it's more of an anti-hormone. And the technical term is called androgen suppression or androgen deprivation, because we're taking away the male androgen hormone testosterone, usually temporarily from the body. So if you take surgery, if you do the surgery pathway, they remove the prostate, they're going to analyze the specimen. They're going to look under the microscope. They're going to say, was the cancer penetrating through the prostate? Was it through the shell, what we call the capsule? Was it in a tiny gland sitting on top called the seminal vesicles? Was it at the margin, the edges of the specimen? Or was it any lymph nodes? They'll sample some regional, and the lymph nodes are, sometimes cancer likes to escape and use the lymph node system to escape the body. It doesn't do it as commonly for prostate cancer like it does for some other cancers like breast and lung cancer, but it can still happen. So it sounds like what you were talking about right there was they were talking about that analysis that they do afterwards, because if you see some of those concerning features, like if it had made it to the lymph nodes, very often we talk about needing hormonal therapy or that androgen suppression, because we know the cancer escaped. And so we need a treatment that can act systemically through the body to catch any of those cells that had escaped the prostate. Just to mention, there is this other scenario where, so if the patient takes the radiation pathway, say they don't have surgery and we're going to do radiation treatments, which as you described can be with seed implants, or we're implanting radioactive seeds into the prostate, that's done under anesthesia. So it's not like surgery, but it is done in an operating room under anesthesia. You're just sticking needles instead of making an incision directly through the skin. And implanting radioactive seeds. The alternative radiation method is to just do what we call external beam radiation. So you're delivering external radiation targeted at the prostate, and the patient usually comes in for a few weeks, every day, Monday through Friday, for a few weeks, 4 weeks, 5 weeks. It used to be 8 weeks, but now we can do it in shorter amounts of time. But if men have aggressive features to their cancer, so I was talking about that risk group stratification. So if they have a high risk cancer, an intermediate risk cancer, a high Gleason score, 8 to 10, a PSA test that's very high, 15 or above, when we do radiation, the studies have shown the radiation is more effective. You get a higher cure rate, a better survival when you add in temporary suppression of the testosterone. So you add in some hormonal therapy. And so sometimes patients, they ask me, I heard I need chemo, or I heard I need hormones with my radiation treatment, or I had a friend that had this hormonal therapy. That's often the scenario that they're talking about. The other last scenario where hormones plays the primary role is when the prostate cancer has spread, throughout the body, or the cancer has come back after these other treatments. They've had surgery, radiation, and now it's come back. Usually that means it's disseminated, it's spread somewhere in the body. Either we see it or we don't see it, but you need something to act on the whole body. And that's going to be the hormonal therapy.
So it sounds like that we have like 2 minutes remaining. So from this, we were able to have this conversation and really talk about a survivor's experience with being diagnosed, with going through treatment. And the thing is that 21 years later, as you said, David, he is here today to share his story and his experience. So David, I would like to ask you in this closing last question, what advice would you give another Black man who may be hesitant about prostate cancer screening? Because it seems like, as I said at the beginning, that screening definitely can help reduce death from this disease.
Any man, period, but particularly African American man at 40 and above, get the PSA test. Ask your doctor about it. You'll be surprised at the men you will come in contact with once you go through this process. There's a fraternity out there, and when they hear that you're going through the process, they come to you and talk about to reassure that you'll be okay. But the main thing is to get the test and follow the directions of your doctor. So please, fellas, if you want to continue to live, and when you turn 40, add that to your annual physical PSA check.
All right. And Dr. Deville, Kurt, I do have, I know I said one last question, but I do have one question for you. Just if you can just summarize in a nutshell, what can we do to prevent this cancer from spreading, among our community and our fraternity of guys, a fraternity of Black men, put it that way?
Yeah, absolutely. Building on Dr. Beckley's comment, it's get screened and get tested, and don't, avoid, ignore. I think we need to really be advocates for ourselves, for our family members, for our communities. This is a new era in medicine that, used to be very paternalistic. You just do what the doctor says. And, I think now we need to understand that this is not that time. We need to advocate for ourselves. And if anything, we harm ourselves when we don't. So if you don't go to the doctor, you're the only one that's missing out, that's losing out. And you lose that opportunity to have the best outcome. Cancer is always, our outcomes are always better. Our survival, our ability to cure, eliminate cancer are always better when we are tested early and pick it up early. And a common thing I hear often is men will say, "Why, I'm not feeling anything. I don't have any symptoms." And usually I say, if we've waited for symptoms from cancer, we have waited too long. Your outcomes are always worse. We always want to stay ahead of the cancer, not trying to be catching up to the cancer. And so, get a physical, see, do your routine primary care, because that's where it all starts. We put so much effort into our cars, our vehicles, our work, every other thing that we do, but we don't do that for our own bodies very often. And actually our family members, our spouses, wives, cousins, friends, they're the ones who are sort of telling us like, hey, have you checked yourself out? And so we, really, we need to take that onus on ourselves and find a good doctor, have a good relationship with your physician. Some of my family members will tell me, well, I didn't tell my doctor that, or they don't. And I say, if you can't talk to your doctor, then you need to find a new doctor. You need to find somebody, because you are only harming yourself by not giving them that information. I want to know, I'll ask the patient, so of all that we talked about, what sounds reasonable? What are you going to do? What are you going to implement? Because we can work with that, right? It doesn't have to be an all or none. And for prostate cancer specifically, I'll wrap it up on this note. I hear a lot about, again, this stigma of the digital rectal exam. Everybody's worried, I got to go have a physical. And that keeps people away from getting the physical. And then they're not even getting the cardiovascular health check, their blood pressure, all the other things that they need. If that don't let that be the barrier to you getting screened for prostate cancer. So, you can decline if you are concerned or worried. They can still do the PSA blood test and interpret it, again, knowing that you didn't also do a digital exam with it. But don't just not go to the doctor because you're so worried or afraid of that. Again, this is your health. You can talk to and have a negotiation with the doctor about, okay, what you're willing to do. And maybe over time, things will change, or change your mind, or something will happen. But again, don't make it an all or none and miss out on the opportunity to save your health, to have your best health outcome.
Well, that was well stated. and to quote you at the end, if you're waiting on symptoms, you have definitely waited too long. I would like to thank everyone for joining Overcoming Prostate Cancer Disparities Through Screening, Prevention, and Genetics. If you want to find out more information about prostate cancer and/or prostate cancer in Black men, please visit the Facing Our Risk of Cancer Empowered website. Thank you once again, gentlemen, for joining us, and let's continue this conversation.